This is Med School Radio. This is Med School Radio, as you know very well, because I always said at the beginning of my podcasts. We're looking at medbullets.com today, Peptic Ulcer disease. The snapshot given. A 65-year-old male presents with complaints of epigastric pain and belching, which improves when he eats food. Remember, it improves when he eats food, but gets worse within a few hours after his meal. He said he has noticed a change in the color of his stool. Introduction. Painful sores or ulcers in the lining of the stomach or duodenum. Breach in the mucosa with extension into the submucosa or deeper. We're talking here about the painful sores or ulcers due to the breach in the mucosa. It occurs when gastric acid secretion outweighs mucosal defenses, and this is most commonly due to decreased mucosal barrier. Think of NSAIDs, H. pylori, or smoking, and it is less commonly due to acid hypersecretion, such as with a gastrinoma. Think of Zollinger-Ellison syndrome. Next, classification. Duodenal ulcers. These are more common and usually in the first part of the duodenum, typically due to H. pylori, which infects the antrum of the stomach and it causes increased acid in the duodenum. It has a low risk of malignancy and is caused by acid hypersecretion or a decrease in the mucosal barrier. So that was duodenal ulcers. Next, gastric ulcers. These are less common and usually in the lesser curvature of the stomach. There is a higher risk of malignancy, and it is not caused by acid hypersecretion. Next, the presentation. With a duodenal ulcer, there is chronic, dull, burning, aching, epigastric pain that may radiate to the back. It improves with meals, but worsens 1 to 3 hours after eating. Remember that? With a duodenal ulcer, it improves with meals, but worsens 1 to 3 hours after eating, and it can wake up the patient at night. With a gastric ulcer, it is mid-epigastric with a gnawing pain, and it is worse with meals. Physical exam. Ulcer perforations can present with pain in the right shoulder, rebound tenderness, ileus as a result of chemical peritonitis, peritoneal signs secondary to acute perforation. As for the evaluation, H. pylori, and you can look at the gastritis topic to learn more about that. And under endoscopy, must have biopsy to rule out malignancy in gastric ulcers. Do not need to biopsy duodenal ulcers. Non-malignant appearance has a punched out margins presentation, and malignant appearance has raised or irregular margins. So non-malignant has a punched out look, and malignant has raised or irregular margins. Serology, serum gastrin to rule out Zollinger-Ellison syndrome. So you look at the serum gastrin. For treatment, lifestyle, discontinuing smoking and NSAIDs is good. Pharmacologically, mucosal protectors, bismuth, sucralfate, misoprostol, acid control, PPIs, proton pump inhibitors, and H2 receptor antagonists. Antibiotics. These are used to eradicate H. pylori. Surgically, parietal cell vagotomy, which is indicated in refractory duodenal cases. Complications. Gastric or duodenal perforations. Abdominal radiograph will show air under the diaphragm. Hemorrhage from left gastric artery in gastric ulcers. Remember, the left gastric artery in gastric ulcers. And from the gastroduodenal artery in duodenal arteries. That one's easy to remember. And another complication could be a gastric outlet obstruction. Thank you very much.